Good morning, David Johnson is my name. I'm a neurosurgeon and spinal surgeon and co-founder of City to Coast Neurosurgery and the Functional Movement Training Centre. A large part of my practice is managing low back pain. I initially had the title of this presentation as Solving the Low Back Pain Puzzle, but I think the title A Paradigm Shift in Low Back Pain Management is more appropriate because this is clearly necessary, but only possible once you have put all the low back pain puzzle pieces together. Putting those pieces together has been somewhat of a professional epiphany for me in the latter half of my career, and it's very satisfying to be able to finally meet the challenge of this somewhat mundane and miserable condition. Now, the objective of this talk this morning is to introduce the new paradigm that I've developed and operate through functional movement training centres. I'd like to convince you that patients are very unlikely to be bunging on their pain. I think the truth of the matter is that we just haven't managed it very well, at least for myself up until now. I'd like to quantify the significance of non-specific low back pain for you and convince you that low back pain can be cured. How, you ask? Well, low back pain is not cured with the current paradigms of treatment, but of course they all play a role. And low back pain is a neurological disease, and therefore it's very much in my scope of practice. Now, it's very timely that there has been a lot of discussion in the media lately about back pain and back pain surgery in particular. This is from the Australian newspaper approximately a week ago. And if you note the caption at the bottom of the screen, medical interventions are seldom the solution. And mostly the criticism is directed towards surgery. And I certainly agree with this, but I'll qualify that later. Here's another online medical journal of Australia article with an orthopaedic spine surgeon cautioning about spine surgery. Somewhat ironic. And another one with two neurosurgeons stating that the low back pain surgery is inexplicably increasing, particularly in private hospitals, with relatively poor efficacy. Now, the undertone is that there's a bit of a money grab going on, but I really don't think there is a money grab from surgeons. I think surgeons do believe that they can fix low back pain, and it's based on a recollection of many success stories, but along with many success stories, there certainly are a lot of failures, and failed back surgery syndrome is a very difficult condition and costly condition to manage. What surgeons just don't understand is why some patients do so well and why some do poorly. Well, if we've got surgery under the spotlight, what is the alternative? And you might suggest physical therapy and core stability. Of course, with weak core stabilizers and deconditioning, it would seem to make sense that if we improve our core stabilizers, then we may be able to improve low back pain through those means. I'm sorry to disappoint you. If you have low back pain, the evidence for this is even poorer. It just happens to be safer and relatively cheaper, but not more efficacious, and therefore it's not unusual for patients to have tried some form of physical therapy. Now, here's a similar systematic review of randomized controlled trials for multidisciplinary physical therapy for low back pain. Now, randomized controlled trial is science's big gun on proving causation. And sadly, the results of randomized controlled trials for a multitude of different physical therapies has been very disappointing, even when compared against weak control groups of doing nothing or sitting on an outpatient waiting list. So at best, billions of dollars of physical therapy gets us poor to moderate and only short-term benefits when compared against doing nothing at all. So let's explore the common evidence-based treatment models. There are three main options for low back pain. Of course, the physical therapies are safe and relatively cheap, widely available. The anatomical-based therapy, and I think MRI has really catapulted this approach and may have opened a bit of a Pandora's box. And finally, treating symptoms with pain therapy approach. Who here is prescribed pain medications for low back pain? We all have treated symptoms, but when we do that, we are neglecting causation. And in principle, that's bad medicine. And of course, you can action a combination of these therapies, which is most commonly the case. The long-term outcome of these paradigms is that they really don't work. And I think we've lost sight of the critical factor required to arrest, reverse, prevent, and cure the country's most prevalent and economically burdensome disease. Do we need to manage low back pain better? Indeed we do. Our current management is not working. Now let's have a look at some of the stats. Taxpayers are hemorrhaging money unnecessarily. Patients and productivity are suffering unnecessarily. $8 billion is an estimate in 2003. I'm sure that's a lot worse now because the rate of chronic low back pain is increasing. Prevalence is extremely high, lifetime prevalence of 80% and a point prevalence of 25%. And low back pain is the most common reason for people to stay away from work. And a single episode of low back pain has a 75% chance of a further episode within 12 months' time, and a 10% chance that you will go on to have chronic low back pain. So, economically, a significant drain on our medical system. And this is an example of someone, 45-year-old lady, a very minor strain injury, pulling a crate out from under a ledge, felt a twinge in her back. Nearly 2 years later, she's not back at work, and you can see how many resources this lady is consuming. I had to read her work cover file, and every single item there is another visit to a specialist, neurosurgeon, orthopedic surgeon, psychologist, psychiatrist. So she's visited a specialist on average every 3 weeks over the last 1.5 years, and not improving. So defining non-specific low back pain, This is the run-of-the-mill patient with an unremarkable MRI that's rested, can't work, taking over-the-counter analgesia. Most of the time the pain settles in 3 months. 10% do not and go on to become chronic. The ones that do improve, 75% of those are likely to have a further episode within 1 year. And I would also lump patients that have had surgery on the lumbar spine and continue to experience low back pain. This could be seen, for example, after microdiscectomy or laminectomy or fusion. Just ask your patients how they feel. And they might say their legs feel wonderful and they are back to doing their job, and their functional capacity is improved well beyond what it was like prior to the surgery. But that may be confounded by the fact that their legs feel so good, secondary to the neural decompression, but they are likely to still report low back pain. Now, we've already touched on the physical therapy and the poor efficacy in the scientific literature. In the mid-1980s, however, randomized controlled trials did show a significant benefit from physical therapy, but this was compared against bed rest. So physical therapy was invigorated by this randomized controlled trial, showing that it was better than rest. And now we have a multitude of physical therapy approaches. I can't explain the multitude of styles of physical therapy other than them all contributing to the annual $8 billion cost of low back pain. Surely non-specific low back pain is not that heterogeneous to require such individualized, unique variations in physical treatment. I think it's more likely that the foundation upon which these multiple physical therapies are based upon is simply incorrect. The motor control exercise, which is commonly practiced, does make sense. We know that muscles become weaker and move with poor control in the presence of low back pain. Let's consider the mechanical crane analogy for a second, where we have powerful high gear motors that lift up a heavy load quickly and move it then with fine control low gear motors and precisely position the load, say on the back of a truck. And that's how our motor control of our back works. And we have evidence that this orchestra of control is lost in the presence of low back pain. Often, even if pain symptoms are improved with short-term analgesia, those motor control mechanisms are still deranged once the pain has eased. And it's a curiosity why Makito in 2009 was sadly unable to show any benefit in the outcome of low back pain management by focusing on motor control exercise. Now, this is an example of patients that have had extensive motor control exercise, trying to get those muscles working properly. And unfortunately, despite the very regular and intensive therapy focusing on muscle coordination, muscle contraction, it just doesn't work. These are patients that have had extensive therapy, and you can see my assessment of their movement when they come to see me after these physical therapies have been exhausted and unsuccessful. Now, my conceptualization of why this approach fails is this. I think it's like training the muscles to play golf, but never actually letting you hit a golf ball with a golf club. You can be as fit and strong and flexible as you can be with your training. But if you never pick up a golf club and hit a golf ball, you will not be a good golfer. And that's my conceptualization of why motor control exercises have failed to obtain a functional outcome in people with low back pain. Let's have a look at the anatomical model now. This approach lends itself to directly targeting perceived pain generators, and therefore by its nature tends to revolve around invasive interventions and surgery. For a surgeon to say there's nothing surgical there, or there's nothing anatomically deranged, I can't help you, I think that's a bit of a cop-out. And as a specialist managing low back pain and spine and performing spine surgery, I think this should be regarded as a failure if you can't offer a patient some form of management in the absence of some anatomical derangement. And this should be regarded as a failure in your audit. I think MRI is the major driver of the anatomical treatment paradigm. MRI lets us see degeneration, and we wrongly target degeneration as the cause of low back pain. Degeneration can become inflamed, and I refer to this as degeneritis. Degeneritis is painful. I don't believe we have good tests for differentiating degeneritis from degeneration, even the nuclear bone scan and CT SPECT. On top of that, surgical treatment for this anatomical change is likely to be misguided. I'll qualify that and explain later why this is an important part of the puzzle to understand. Now, surgeons have all had wonderful successes and also cases we'd like to forget. But here's a patient of mine that had pathology that I deemed required surgery at L4-5 and L5-S1. Now the question is, did I cure this patient's low back pain by stabilising those two levels? And the answer is no. Why is he now pain-free, highly functional, and back to his highly physically demanding job and feeling 100% healthy? I hope the answer will become apparent to you shortly. Now, I love the practice of surgery, and I've spent a large portion of my life learning this art, but when it comes to low back pain, I really had to question the contribution that I was making to people's lives. All the different forms of surgery here, XLIF and anterior lumbar interbody fusion and pedicle screws, posterior lumbar interbody fusion, transforaminal lumbar interbody fusion. I perform all of these surgeries: keyhole, minimally invasive, maximally invasive. Sometimes they work, and sometimes they worked, and sometimes they didn't. My epiphany was understanding the key element required for success across the board, and it was not specifically linked to my surgery. My surgery didn't really change. The surgery was required in certain patients, but if I left out the additional key element, then it would often result in failure. And then surgery is blamed as being unnecessary or over-treating or the cause for the failure. And I think that's very misguided. That's why I know that people who say surgery or other therapies for that matter, be it physical therapies or physiotherapy or motor control exercise, or your pain specialist who applies their trade for patients with low back pain, if they say that those therapies don't work, then they haven't solved the low back pain puzzle. The three treatment paradigms practiced today that I showed earlier and just mentioned are not actually intended to be the cure for low back pain. They merely allow for the key element required to cure low back pain to surface, and I'll go into that now. Just briefly, there's some more anatomical intervention papers that show very questionable outcomes from low back pain surgery. There was some early success in the Swedish lumbar spine group, but more delayed follow-up papers have shown that back pain is recurring even in those early success cases, which is consistent with the earlier epidemiological statistics. The pain model. Patients have pain. Of course they do. Let's treat pain. How good is this approach? Just remember that with this paradigm we're only treating symptoms and not causation, so it is unlikely to ever work in the long term. For example, if changing your worn out car tyres beneficial if the wheel alignment is off? No, of course you'd fix the wheel alignment, and then your car tyre wouldn't deteriorate as quickly. You wouldn't just go and put a new car tyre on. You treat the cause, not the symptoms, and that's common sense and good medicine. An important message to take home is that pain causes abnormal motor efference, altering the movement patterns, and with chronicity, pain processing in the brain is reorganized, which is part of the central sensitization concept. Movement patterns are groups of singular movements linked in the brain like a single application of information, the software of information that governs movements for a specific function, such as sitting or picking something up off the ground. For efficiency, when this task is required, the whole application or the whole program in your brain fires to efficiently execute the movement-driven task. Now, I'll give you an example of that. This morning I was brushing my teeth with an electric toothbrush, and that's a task that I do without even thinking. It initiates a movement pattern in my brain. While I was brushing my teeth, the battery went out on the electric toothbrush, and I continued to brush my teeth. And when I finished brushing my teeth, of course, with the electric toothbrush that wasn't actually vibrating, I still brought my finger up to turn the button off, even though the machine was already off. And that is a classic example of a motor program that's activated by a task, and it's almost automatic. And because normally when I perform that task, my brain remembers, okay, when you finish brushing your teeth, you've got to turn the machine off. And even though the machine was already off, my thumb still went to perform that motor task. And I was doing that this morning. I thought, oh, there's a fantastic example of a motor program in practice, and I'll use that in my talk this morning. So, in the presence of pain, these motor programs and therefore the movement patterns become deranged. New movement programs have overwritten the normal ones to accomplish the movement tasks. The difference may be dramatic or subtle, but nonetheless, the motor program for the movement is now an entirely corrupted program. Here's a very quick example of someone who has pain, and there's clear evidence of the motor program slowly becoming corrupted, which manifests in obvious gait disturbance and uncoordinated muscle contractions. There are many pain therapies. Neurostimulation is a particularly powerful one that I use a lot. Here's an example of a spinal cord neurostimulator. Here's an example of peripheral nerve neurostimulator targeting the clinial nerves. And here's a dorsal root ganglion neurostimulator targeting the DRG of the lumbar nerve roots. These are very powerful at masking the ascending pain signals. The big question is, does my neurostimulation procedure definitively cure my patient? Again, the answer is no. At least it does not. It is not effective without the critical component required for long-term success, because all I'm doing is fixing up symptoms, not causation. So let's explore the success stories. We all have success stories, but why were they successes? The surgeon's successful fusion, the physiotherapist's successful motor control cases, chiropractors have very thankful patients. Musculoskeletal physicians will action prolotherapy with grateful patients. Even radiologists might fix a compression fracture with a cementing procedure, and many of these get better. Could it simply be a fluke? Why isn't it across the board? If we understand what was common to our successes, we would have a model that would have an overwhelming and resounding success for everybody, generically.
There is no other option but to have surgery for both of you, yeah. Okay, and has the outcome been the same?
No.
Ah, that's it. What's happened?
We both work for the same company, so we do the same sort of job. I'm in Melbourne, of course, in Sydney, as I said, and after the surgery, Nicole was given a stand-up desk, and I wasn't. So I'm still in a lot of pain, I'm still on painkillers, and still dealing with the issues, essentially, whereas Nicole isn't. And that's pretty much almost 100%.
So, what a mystery. Twins, same pathology, same operation, it was a microdiscectomy, and one twin is 100%, the other one's still in pain on painkillers, and there was one clue that the recovered twin mentioned. She had a stand-up workstation. A new model for low back pain is well overdue. Now, sedentary behaviour and age should not equate to higher rates of low back pain. Sedentary behaviour and age will no doubt result in different degrees of functional capacity, or how much work we can do, but I would argue, based on my concept of the new model for low back pain, is that a labourer and a bank manager have equal ability to either suffer or not suffer from low back pain. The critical concept in this new treatment paradigm is that movement quality should be no different in grandma as it is in the Olympian. Of course, the functional capacity is greatly different, but the way that they move should, however, be identical. So, picking up the groceries in terms of the biomechanics and the quality of the movement should be no different to the way I'm training and doing, for instance, a deadlift or a front squat. I'm just doing I'm just moving a greater load here, but my biomechanics are no different to the Olympian. And the same should go for grandma as it does for an athlete. This brings us finally to the working model for low back pain, and I refer to it as the functional movement model. I'll refer to the descriptor functional shortly because it has a very specific definition. This model is based on the acquisition of movement deficiencies imparted on us by modern society, which eventually results in functional requirements exceeding functional capacity. Observe the subtle differences in these two pictures. They may look similar, but the movement pattern is entirely different, as we discussed earlier. Why do we have these different movement patterns? Modern lifestyle inhibits this worker moving his body the way that it was meant to. The picture on the left, in less industrialized cultures, shows the same movement pattern that a toddler displays when he picks up a toy. what is movement and how important is it? Well, Hippocrates around 400 BC realised how important movement was, and he referred to movement as life. And I refer to the triad of dying healthy, and I believe that the triad involves 3 essential elements: nutrition, sleep and movement. And movement is made up of coordination, mobility and strength. If you compromise any of these 3 elements, then that leads to poor health. These are the 3 things that we're in control of that can be compromised, leading to poor health. Here is our model again, and there's our toddler showing his uncorrupted movement patterns and squatting like the adults in the poorly industrialised countries. And notice the difference between the movement positions. People like this worker who have difficulty activating the motor program for squatting leads to deactivation of the posterior chain musculature to accommodate inflexibility and weakness of the hamstrings and glutes and the hip and ankle joint. This movement deficiency feeds into the cycle of pain. Now, as I mentioned, the toddler has not yet had time to develop these movement deficiencies and squats like adults in the non-industrialised countries, which classically have a very low prevalence of low back pain. Now, labourer or bank manager, who is more likely to have back problems? If they both move well, neither have low back pain. The labourer, however, has the greater functional capacity. Of course he does, because he's more powerful and can do more work. But if both move with deficiency, both will suffer low back pain, even the banker who's sedentary. The physical demanding job is not the contributing factor. The common factor for low back pain is movement deficiency. This is a neurological motor pattern disease actively imparted by modern society. The key element for success is engaging movement training or re-establishing the correct movement patterns at the same time that you action the 3 currently existing treatment paradigms. Now, I go as far as referring to the movement training as the sport of movement, and like any other sport, to be good at it requires coaching and practice for most people. Now, this is a very key slide. So my patient who I showed earlier, I did not cure them. I restored their ability and potential to participate in the movement training for the sport of movement. The movement training is what cured them by rewriting the correct movement pattern programs. That should be the ultimate goal of the 3 current treatment stepping stones. Anatomical treatment such as surgery, pain treatment such as a neurostimulator or a facet joint block or a epidural, and then the physical therapies that our physiotherapists might employ to improve core stabilizers or enhance some motor control components. These are stepping stones so that you can then re-engage your normal movement patterns, and most of the time these normal movement patterns need to be assisted back by movement training. Just like if you wanted to learn how to hit a nice golf ball, you would need to visit a golf coach. Likewise, when you have movement deficiencies, you need to visit a movement coach. Do not consider your current prescriptions for low back pain management as the treatments or cures. Surgery, physical therapy, pain therapy should only be regarded as stepping stones to enable the reacquisition of movement. In a minority, movement is restored independently, but for the majority, only with specific movement training, particularly if pain has been chronic. Here is an analogy. Imagine a bad golfer who gets a lumbar spine fracture and naturally feels pain. If the lumbar spine fracture is cured with surgery, for instance, does he suddenly become a good golfer? No, he's still a bad golfer, but he has the potential to then seek out golf coaching and then to become a good golfer. There are some patients like Tiger Woods who develop a bad back, as he did with a disc prolapse some years back. He has back surgery. After the back surgery, is he a good golfer? Of course he is, because he already had that movement capacity prior to his movement obstructing barrier, which was the back injury. That is what explains success when we action our current therapy paradigms, and patients do sometimes get better, but it's inconsistent, and it misleads us that the therapy that we employed, such as surgery, was the cure, and misleads us into repeating that time and time again. But many patients are not able to independently regain their motor control patterns, and they need assistance. These type of patients are the minority that can gain their motor patterns back independently in the face of pain, and resolution of the low back pain was a result of regaining that movement after treatment, not the treatment per se. Most people, however, need assistance to regain these movement patterns. I need to remind myself that my movement obstructing barrier surgery did not cure these patients. The return of their own preserved movement proficiency that my surgery imparted was what cured them. So I now don't leave it to chance. I apply movement training to all my spinal surgery patients. Now, just to reiterate the fact, I'm elaborating now on the movement obstructing barrier concept, MOB, movement obstructing barrier. Movement obstructing barriers need to be addressed prior to engaging in movement training. There's no point engaging in movement training when you've got a big disc prolapse, or when you've got a fracture, or when you've got spinal stenosis or a severely degenerate segment. Of course, fix up the anatomical deficiency, but leaving this out will very likely result in persisting back pain and failed back surgery. If someone has incredible pain due to those protective mechanisms that the brain employs to let you know something's not right, or if central sensitization has reached very high levels, then spinal cord neurostimulators may be required. But that's not the end of the story. Engage in movement training afterwards, because you know that their movement patterns are going to be deranged. If someone has very weak spinal extensors, very weak core stabilizers, strengthen those up with isolated physiotherapy and then engage in functional movement training. Isolated physiotherapy is not functional movement training, and that explains why Makito in 2009 saw no benefit in low back pain when he just employed motor control exercises, because he wasn't engaging patients in movement training. How do we reacquire these motor patterns required for this sport of movement, as I've described it? I already showed that physiotherapy or physical therapies failed us badly. Nearly all of my patients with low back pain attend functional movement training, and you can see from this that movement training is quite unique. It's time consuming, it's labour intensive, exhausting, and requires attention to the detail of movement, and therefore would not be economical for many physical therapy delivery providers. Also, and uniquely, is that the patients have to be prepared to do the work. Patients are all doing the work. There's no passive elements at all, and specific attention to detail must be incorporated. You have to have the skills as a functional movement coach. I'll just show this video. Who are functional movement coaches? Definitely not these PhD physiotherapists.
Brittle bones. Chin over the butt. Good, now come down. It's a new way to prevent crippling osteoporosis. High-intensity weight training in the 8-month study by Griffith University has found the opposite.
Since this, I don't fall.
Now Robin Anderson is deadlifting
Between 50 and 55. They have a broken bone.
because they are stronger.
Coming here, I've built up my spine 8%.
Physio, one lift at a time. Lexi Hamilton.
So this video shows fantastic intentions by the physiotherapist engaging in resistance training, and there were some functional movements that were being employed in that video, but it highlights absolutely and categorically that physiotherapists are not movement coaches. The movement training in this video is cringeworthy, despite the distinguished and academically credentialed investigators. They have no credentials in movement coaching, and therefore I was not comfortable sending my patients to physiotherapists for functional movement training. There are 2 functional movement training centres in Queensland. Now, I did a Google and Wikipedia search for what functional movement was, and it's fairly bland. There's not a very elaborate description of it, given that it's such an important element of this treatment paradigm. The Google says that functional movements are movements based on real-world situational biomechanics. They usually involve multi-planar, multi-joint movements which place demand on the body's core musculature and innervation. So, accurate, but not comprehensive. I have a clear, goal-specific definition of functional movement. This is at the heart of functional movement training. This is the engine, so to speak, of what drives the change in the motor patterns delivered by the brain to the spine. The most important element, I think, is the fact that a functional movement is an irreducible, core-driven movement and has the unique ability to express power. These are some other elements that are important when we're engaging in functional movement, and they were completely ignored in that earlier video. I'll just show you this video of patients engaging in functional movement training. Observe the progression from pain and dysfunctional movement to normal pain-free movement in a very short space of time. This fellow in particular, 2 years of physiotherapy, time off work, a lot of money, and after about 4 to 6 weeks, movement patterns restored, moving normally. Another example, 3 months of 1 to 2 physical therapy sessions per week, and just horrible movement patterns causing more pain. It looks painful. It is painful. Here she is starting movement training, the Functional Movement Training Centre, maintaining neutral spine, cues, hip hinging, activating a posterior chain, slowly building up that default movement pattern. Her nervous system is changing, and with that change comes a reduction in pain because the brain no longer has to send you that signal. And that is extremely satisfying to see that in such a short space of time compared to lengthy, poorly efficacious physical therapy that just goes nowhere and gets worse with time due to the cycling process of pain and movement deficiency. So functional movements are powerful by their inherent nature. Power means doing more work more quickly, as expressed in physics by force times distance divided by time. Generating more work means greater intensity. Now, I can walk up a flight of stairs quickly, or I can do it slowly. I've done the same amount of work, but if I do it quickly, the power that I've expressed is very different and my body feels very different. What I'm feeling is what's referred to as intensity. Now, intensity is a key concept and well studied and shown to have a significantly greater physiological effect on the body. That effect on our low back pain patients is imparted by neuroendocrine adaptations. Now let's think of the neuroendocrine adaptations that need to occur for patients to get better. Their nervous system has to change, central sensitization has to slowly unwind, patients' cognition, they have to overcome fear avoidance, and of course restoring their normal motor patterns, which is a neurological process. We want musculoskeletal changes. Functionally, we want stronger hip extensors and core stabilizers. Soft tissues need to change. They are all pain generators, and if they become healthier, there is less afferent nociceptive signaling. Now, also a very important factor to understand is that grandma and the professional athlete who have back pain can perform different amounts of absolute work in the same time domain and both reach the same relative intensity to get that same neuroendocrine response. You can see varying ages, varying degrees of functional capacity at this stage, all with low back pain, all engaging in functional movement training, which by its very inherent nature creates intensity, activates core, maintains neutral spine awareness, and patients start to transform. Now, many motor control exercise training programs and physical rehabilitation clinics consciously avoid intensity and avoid functional movements for this very reason, because functional movements are intense. In place of this, they adopt a reductionist approach to movement, which is a distinctive and significant difference. For example, the favoured couch. In the functional movement training centres, there are no couches. Reductionism in science creates a simpler, understandable perspective, but destroys the global picture. Like a body is destroyed by the study of dissectional anatomy, movement is destroyed by reductionist motor control exercise. There is no conjecture in the scientific literature that intensity, or more specifically relative intensity, has a significantly more profound physiological effect on the body. Hormonal mediators are BDNF, brain-derived neurotrophic factor, growth hormone, adrenaline, cortisol, endorphins, serotonin. In the past, we have not been able to integrate this into conventional physical therapy models for low back pain. We finally can with functional movement training. Engaging in functional movement training by its very definition incorporates intensity, and I believe this is what distinguishes functional movement training as a paradigm shift in low back pain therapy. The results so far are embarrassingly favourable in generic, unselected, non-specific low back pain patients, and we are awaiting publication. In my view, the experts in spine surgery and pain management and physical therapy should understand this model of low back pain management if we are going to start to meet the challenge of this demanding problem. And unfortunately, every day I receive referrals such as this one, where patients have had back pain, they've had epidurals, they've tried physiotherapy, and surprise, surprise, after months and months, their low back pain is getting worse rather than getting better. Now, can you please see them to consider surgery? And injured workers who have been in a similar situation, They've had their physiotherapy, there's nothing on the MRI, just degeneration, and the degeneration here is being blamed for the ongoing pain. Why haven't they recovered from their time off work and poorly efficacious physical therapy? They're now stable and stationary. If they can't go back to work, then they'll get a permanent incapacity assessment and unlikely ever work again. That's the sad truth that we need to get away from. This approach had more impact on my practice as a surgeon than any cutting-edge technology in the last 10 years. It is transforming disabled people back into domestic and industrial athletes proficient in the sport of movement, a sport that we are all mandatory participants on a daily basis, second by second, and it is that second by second movement that determines our long-term spine health. Thank you very much, and I'm more than happy to take questions.